Thank you for your recognition and for inviting me to this course every year. I greatly appreciate it. So these are my disclosures. So the title of this talk is Tips and Tricks and on Deformity. And so, one of the things I figured I'd start out with is that deformity is actually incredibly common. So it's one of those things that if you actually pay attention and order some x-rays, aside from the MRI that, that usually sometimes the primary care physician orders in advance without ordering x-rays, you'll see that on routine x-rays, up to 68% of volunteers over the age of 60 have scoliosis. So very important, just as a tip, to just, search for it, because deformity is there if you look hard. Or yeah, you don't even have to look that hard. It's going to be there. So again, this reiterates the importance of x-rays. So the advantage of the x-ray is that it's fast, it's inexpensive, doesn't require prior authorization, and very importantly, it has a dynamic quality, and that you can assess what the deformity looks like while you're standing. When you're supine, you can determine flexibility. And very importantly, we know that through Glassman's study, x-rays are the mechanism through which we assess a patient's sagittal balance and calculate all of our pelvic parameters and pelvic tilt. This is very, very critical. One of the little things that you can notice when you are evaluating patients is that there's information that is embedded into various images, and you just can look a little harder and you can find out some pretty cool information. Depicted here on the left is a scout image of a CT scan. On the right. On the right is the scout image of a CT scan, and you can see the standing X-ray shows a profound positive sagittal balance. And if you just look at the CT scan scout image, you can see how much that corrects when he lays down. It's a pretty big difference between standing and laying down. And you sometimes you might not be in a position to request multiple X-rays, and these patients are very debilitated people who can't move around very much, and they have a hard time getting X-rays and going to the X-ray department to get another film, and for them to lay down is a big task. So if you can derive information from a scout, you might as well take it, and that's going to be their supine comparison to the standing X-rays. So other important tips, you want to look at the disc spaces on the CT and check if there's gas in the disc space. If there is gas in the disc space, that's a hypermobile area, and you could take advantage of that during your planning for corrective procedures. You can also get an idea about the degree of bone quality that is present. You can measure Hounsfield units on the CT scan, and you can see whether or not there is any hint of osteoporosis, and that could prompt getting a DEXA scan and getting vitamin D levels and those kinds of things. So we're all familiar with the radiographic drivers of disability and the surgical goals. And again, to reiterate that X-rays is the only way that you're really going to get this information. So, there are a variety of treatment options for deformity, and a lot of the treatment depends on what your experience has been with other patients. We all have anecdotal experiences that influence us, and we see something that worked well for one patient, and we are more likely to try that in the subsequent patient. But still, the gold standard for deformity is open surgery. That's pretty much the gold standard. But as time progresses, and Juan, I'm sure will discuss with us, this will advance as time passes to more minimally invasive techniques. And you can sometimes get the best of all worlds by doing hybrid procedures. So I'm going to go through different cases and discuss different tips and different pearls through these different cases, and you can usually learn a little bit from each and every case that you do. And we're going to go from more invasive to less invasive, and then talk about some technical pearls. So first case is a 59-year-old with a previous history of a T2 to pelvic fusion. She had this done in California prior to moving to Maryland. And at the time she moved back to Maryland, she was treated for a pseudoarthrosis at L23. The referring doctor felt that everything in the construct was solidly fused with the exception of that L23 level. And so he removed the hardware distally and did a 2-3 lateral interbody fusion. So initially the patient did well, but then several months later she presented with kyphosis and severe sacral pain, as well as urinary incontinence. So this is her situation here. You can see she has a plated lateral construct at L23. The distal hardware was pulled out. You can see a broken remaining portion of the iliac screw, and so you can see she's in a pretty bad state. Has cauda equina. You can see the reasoning for the cauda equina is that very bad sacral fracture, and this lady was unfortunately in a very bad situation. So I guess Tim Chryssikos, one of my residents. He's pretty familiar with this case because he wrote this up not too long ago, and I'll go ahead and discuss the decision-making process with you guys. So what would you do with this situation? So maybe let's see. How about Michael Carsey?
Well, it sounds like this patient has really poor positive sagittal imbalance, and I think what you need to do is extend this fusion down to the pelvis somehow. The challenge is with the fracture, how do you do that? I mean, if you have additional films of the iliac crest, maybe you can look at iliac bolts or the S2 alar screws.
Right. Yeah, that's reasonable. And so what else do you want to calculate with regard to the sagittal imbalance? I'll just let you know. Her pelvic incidence was I think around 40, and she had 0 degrees of lordosis. So you basically you want to plan a procedure that's going to restore the lordosis, and in this case. For her, we needed to extend the fusion down to the pelvis. We needed to obtain some additional lordosis. So this is one of those cases where we needed to do a big open pedicle subtraction osteotomy. We contemplated doing the osteotomy lower down in order to get maximal sagittal realignment. But that was the area where she had multiple previous surgeries and laminectomies, and so we were a little worried about creating a potential new problem with all of the scar tissue and the redundancy of the dura that you get when you close down the osteotomy site. So we decided to go to the L1 area where everything was fresh and there was no scar tissue. And so this is a depiction of the thecal sac. It's a little dark, but you can get an appreciation for the wide nature of the decompression and the exposure of the exiting nerve roots both above and below, and the osteotomy was closed down, and you can see that she had a solid restoration of the alignment, and over time she had resolution of this fracture. So yeah, she ended up doing well, with the exception of one thing. She developed heterotopic bone at the site of the PSO site, and this, I think, was in conjunction with the use of BMP, and required more surgery to remove that heterotopic bone. So that's an example of a maximally invasive procedure, but something that you had to think about was not only the sagittal alignment, but also the caudate equina syndrome secondary to the sacral fracture, and fortunately she developed resolution of these problems. So this is a 52-year-old physician coming in with this scoliotic deformity, requesting minimally invasive surgery and maximum preservation of her mobility. So you can see she doesn't really have a lot of stenosis. She has a couple disc spaces that are pretty collapsed, with the scoliosis centering at those levels at 2.3 and 3.4. So overall, her sagittal alignment is not terrible. She's able to stand pretty straight, but primarily has a lot of back pain and has some associated radicular symptoms secondary to the wedging of these disc spaces. So this, I thought, was a perfect candidate for a minimally invasive type of surgery through a lateral approach with posterior perc screws. This is a situation where she didn't need an aggressive decompression and needed some improvement of her back pain. And so this is what she ended up getting, a trans-psoas inner body fusion with percutaneous fixation. So she did very well. She returned to work in I think about 2 weeks, and was doing very well. So she had a very fast recovery. She left the hospital, post-op day 1. So a big difference from what I usually do with regard to the large open cases that I usually do. So another physician, this is a 74-year-old who had a history of a lumbar decompression and developed some progressive kyphosis. Distally, he at the site of this spondylolisthesis, he actually had a spontaneous union, but he was left with significant residual stenosis in the neural foramina. And so this, given his age, he was a 74-year-old gentleman. I wanted to try to come up with an approach that was not going to result in severe blood loss. So this is a gentleman who, again, I wanted to try a sort of a hybrid type situation where not doing a huge construct, but trying to improve him partially. And so this again was another patient who had this was an oblique lateral interbody fusion. We had originally planned to do lateral interbodies at all of the levels, but as you can see, the most caudal level of the construct, we were forced to do a T-lift because during the operation, we got a lot of EMG activity despite trying to go in front of the psoas or through the psoas. No matter what we did, there was a lot of EMG activity. So we had to abort that level and address this posteriorly during the posterior fixation. But the end result was very positive. He returned to work. And he is very, very content, and we had the latitude to do a nice aggressive decompression of the neural foramina as a result. So you can see coronally he improved, and sagittally he improved. He's 74-year-old, so I didn't really want to do a total correction of his entire construct or his entire spine. So this is a 55-year-old female, again, with significant scoliosis, worsening back pain and leg pain. She had a 60-degree pelvic incidence, and as you can see, she's has only 25 degrees of lordosis, and her pelvic tilt is normal. So again, this is a situation where looking at the gas and the disc spaces and the nature of the collapse and the morphology of the scoliosis, you can create a targeted approach to the treatment of this patient's sagittal alignment. So, she needed 30 degrees of correction, so we decided to try to do some intradiscal work with expandable cages and taking advantage of a few of these hypermobile areas. And this is similar to what Jens presented yesterday with regard of trying to put in these expandable cages into the disc spaces to increase the anterior column and obtain a better sagittal alignment. As you can see, she had a significant improvement in both her coronal and sagittal alignment just through these two intradiscal preparations. So, moving on to the intradiscal theme, I wanted to present a few cases where, we really did more of this intradiscal work to further loosen the anterior column and obtain even greater sagittal correction without doing a PSO. And so these are the disc spaces where you can really take advantage of this technique, I think, are those that are collapsed but still have evidence of gas. And when you really want to get an aggressive correction through this technique, I use very blunt disc-based dissectors bilaterally to basically just barely break through the ALL, just barely. So if you get this all the way to the very anterior tip of the disc space and just very, very carefully release the anterior longitudinal ligament, you can really get impressive results. This is an example of a patient who had significant kyphosis above this construct. We contemplated doing 2 PSOs in this gentleman due to the amount of sagittal imbalance that he had. And this patient was capable of being treated through this approach. Cephalad to the previous construct, as you can see, we have bilateral blunt disc spacers placed into the disc space just at the level of where the coronally where the pedicle screws are, and you put these in, and you just get to the very, very end of the disc space and rotate these blunt disc space preparation tools. And as you can see, you're able to take a kyphotic disc space and turn it into a lordotic disc space. So as shown here, there was a 12-degree kyphosis, which changed to a 8-degree lordosis, so a 20-degree correction. This is another example of a patient who had an old construct, and between L1 and L2, you can see there was a 9-degree lordosis. This changed to a 15-degree lordosis, and or no, a 17-degree lordosis. So we achieved a substantial correction in this patient, again through the same technique by expanding the space in the disc space. So this is a depiction of that improved sagittal alignment. And another example of a patient who, similar situation with that gas in the disc space above the old construct, putting in one of these expandable cages to further lengthen the anterior column. This one happens to be an expandable banana cage, so rather than putting in the bilateral cages, this was an expandable banana cage that really helped lengthen that anterior column and restore this patient's sagittal alignment, and just showing before and after. You know, one of the pearls is to carefully examine the nature of the end plates. There are some patients who have had such a strong chronicity to their disease that there is very sclerotic margins of the end plates. And when you have that significant sclerosis of the end plate, you know that you can actually use that to your advantage and apply a significant amount of force to help break open that space without subsiding. This is an impressive correction. You can see how kyphotic that one disc space is. This is a patient that we consented for a PSO, but we were actually able to just very carefully and bluntly get into that disc space and break through that anterior longitudinal ligament. And we put in this hyperlordotic expandable cage. And again, you can see that a wonderful result with the restitution of that lordosis without needing to do a lateral or any other major operation, minimal blood loss. So as far as the last pearl is just to remember about patient selection. Not everyone is a perfect patient for a large deformity operation, and these are patients that should be seen in your office on more than one occasion, so that you've had an adequate opportunity to counsel them about potential for complications. And you want to really optimize the health of these patients prior to surgery as much as possible and obtain appropriate medical clearance. So all of these are factors that can potentially influence your success. So the bottom line is we have a wide variety of treatment options for patients, and if you pay particular attention to the specific features of their x-rays and their preoperative images, you can come up with a treatment plan that hopefully would be very suitable and could potentially reduce their morbidity. And I think as time passes, there's less and less of a need to do a PSO, and there are other options that can be done with less morbidity. Any questions? Hey, Rod.
Charlie, great talk. So I have three main questions. Number one, do you use titanium or cobalt chromium? And then can you just talk about rods and whether 1/4 inch versus the 5.5? That's number one. Number two, when do you use quad rods? Like, Dr. Mendel yesterday he said he uses it on every case. And then the third question I have is, I know you probably never get this, but we seem to get a lot of patients who have proximal junctional kyphosis. And in our practice, what do you think, Jens? Like 30%?
100%. Let me start there. Long fusions. Where do you stop? Can you stop at T12? How many patients get the transition zone breakdown of some magnitude?
So I definitely think that, there's a lot of, teaching that you should stop the construct at T10 or T11. But, I don't know how much science there is behind it, because I remember reading one paper from Lanke that showed that the rate of PJK didn't matter at whether you ended the construct at T9, T10, or T11. It still was going to happen. So PJK depends on a variety of things, but I think the most important thing that it depends on is bone quality and whether or not you have achieved a satisfactory sagittal alignment, and whether or not you've done an overcorrection. So there are a lot of things that factor into it. For certain cases, I think it's okay to end at T12. And for certain cases, I think it might be okay to go up higher. If I'm worried about the bone quality, and I routinely put cement in at the top of the construct and one level above that. Not that, I so far haven't really used those tensioning devices that apply tension one level above the construct as a sort of like a dynamic stabilizer. So I don't have a perfect answer.
Bob Hart uses that technique.
We happen to talk about something that you don't know about, PJK. Should we use these transition zone cables or not to prevent PJK for long fusions?
So,
Yeah, again, he knows that we're talking about this.
yes, right. So, so PJK is one of the still unsolved problems of adult deformity. I think there's a patient planning part, so preoperative, and I'm sorry because I don't know everything you've been talking about, but preoperative optimization of bone density is critical. I think the prehab physical therapy is important. If you can get their muscles more conditioned, get them some weight off, that helps. And then the planning of getting the alignment right. So you want to have them in a young person in their 50s, you want to have them neutrally aligned according to kind of the PI minus LL, pretty well matched. Somebody in their 70s, it's better to have them a little forward. They prefer to be a little forward. So the alignment goals now are coming out. They're age-matched alignment goals, and so hitting those is important. A third thing that I think is critical in the OR, we're moving towards pre-bent rods now, so patient-tailored rods, and Chris Ames and Sig Bervin have been working with Metacrea, I think, more than maybe most centers on that, but that's the only company right now, I don't have any conflicts, I should say, with Metacrea, but that's the only company that has a patient-specific rod available. But the problem in my mind with that is that the rod comes and it's going to go in and move the spine at the top to whatever that contour is. So my preference is perhaps to have the lumbar contour in, but the upper junction remains uncontoured, and then you bend the rod in the OR to the spine. So you're not pushing the spine to the rod, and certainly not pulling the spine up to the rod, so there's zero preload on those upper implants, whatever you use. And then I have done cement for a number of years, and it works, but I worry that in the sense that it reduces the risk of fracture, but I worry that it may create a difficulty for the disc, so it robs nutrition from the disc, and it may create a biomechanical environment for the disc. If you do, what we ultimately were doing was one level above, and then the top level of screws. And I think that clearly reduces the incidence of PJK, but may not bode well for the long-term health of the upper disc. So I've gone to posterior column augmentation, and the two ways that you can do that are with rib augmentation, grabbing the rib of UIV plus 1 and tethering that to the construct, or transverse holes through the spinous processes and weaving UIV plus 1 usually into UIV and maybe UIV minus 1, and then tethering that to the rod. And there's a video on YouTube from a course a year or two ago that showed both of those, if anybody wants to take a look at it. Chris Ames and I think Shaffrey really developed the spinous process technique, and I used the rib tether for probably 3 or 4 years. I don't know, something like that. But both techniques now have large numbers of patients with very few failures.
And then quickly, so thank you. That was a very cool brief overview. We could spend all day on this. Finally, Charlie, Dr. Kazemi gave a nice talk about metals and implants yesterday, but one more time. For long adult deformity, 6.0 rods, 4 rods, cobalt, chrome.
Yeah, my preferred metal is titanium, and for long constructs, I think it's good to do larger diameter titanium, 660. And for shorter constructs or constructs that have or patients who have very solid bone quality, cobalt chrome could be used, or titanium alloy, which is stronger than commercially pure titanium.
And selective 4-rod assemblies.
And so 4-rod assemblies, I think, are particularly good for patients who have a PSO or a disruption of the ALL. So I think 4-rod constructs are good in those cases.
Super. All right, Isaac.
Can you explain your rationale in adult deformity in terms of using cobalt chrome versus titanium? Why do you prefer titanium versus cobalt chrome?
I worry that cobalt chrome is too stiff, and I personally think that, I mean, it's just my own bias, but I feel like in patients in whom I use cobalt chrome, that that I had more PJK.
All right.
It's interesting because the prospective study by ISSG, I think Justin Smith was the first author, where they looked at the rod fracture rates for PSOs, and the highest incidence of rod fracture rate was with cobalt chrome, which was kind of interesting. And so I'm not sure if that's because one of the reasons that they postulated was that perhaps the cobalt chrome rods were using much more severe curves where they had to really contour the rod and may have induced some notch effects into the rod. So,
Nuj, any thoughts? And then we'll close.
I agree. I had one question for Charlie. In long constructs, how often do you insist that you fuse L5-S1? What do you think the role of L5-S1 arthrodesis is when you go to T10 to pelvis?
So if the patient needs, so you're asking about inner body arthrodesis?
Can you skip L5-S1?
Yeah. If the patient does not have a lot of foraminal stenosis, and I don't have to do a facetectomy, if I could get a solid decortication just by decorticating the facets, and sometimes I might skip it, but in general, I think it's very important to have a solid foundation and to do inner body arthrodesis at 5-1.